And now we are going to start our next session. The topic is bleeding in the immediate postoperative period. For this session, I would like to invite our chairperson, Professor Sadaf Ali from Srinagar. She is in working schemes, Srinagar, India. And other chairperson is Dr. P.K. Mishra. Dr. P.K. Mishra is presently Senior Director and Head of Department Surgical Gastroenterology at Max Hospital, Delhi. He was earlier Director and Professor at G.V. Pant Hospital. He has edited a popular textbook of GI surgery and has a long teaching and clinical experience. And I request our chairperson to invite the faculty speaker for the presentation.
Thank you, Professor Kapoor, for organizing such an in-depth conference about one of the commonest operations performed worldwide. So, bleeding complications. I hope I'm audible.
Yes, sir, you are audible.
You are audible, sir.
Bleeding complications have not received sufficient attention, like biliary injuries in laparoscopic cholecystectomy. In fact, when Professor Bansal was also speaking, he did not cover the bleeding aspects of the laparoscopic cholecystectomy. But they are one of the second biggest cause for mortality in laparoscopic cholecystectomy. And bleeding complications can occur right from the trocar insertion to in the late post-operative period. Surprisingly, post-op bleeding is not well documented in the literature as well. Indications are explorations and operative findings are also not well documented. So this topic is very important, bleeding in the immediate post-operative period. And I have the pleasure to invite Professor Ender Dulundu for this topic. He is Professor of General and HPB Surgery and Director of Liver Transplantation at Hospital Istanbul University in Turkey. So Professor Ender Dulundu, please.
Ma'am, sir, we would like to play the video of sir. We have a video of this presentation. We are going to start the video.
Meeting. It's a great honor and pleasure for me to be with you. My topic is bleeding in the immediate postoperative period. We can divide the complication of cholecystectomy as a biliary and non-biliary, and regarding to the non-biliary complication, bleeding, bowel injury, injury to the other intra-abdominal structure, and pneumothorax can be said. And majority of these are operator dependent and largely preventable. I'm going to talk about the incidence, mechanism, prevention, and management of the bleeding complication in cholecystectomy. When the bleeding remains unrecognized, mortality reportedly goes up to nearly 15%. And second most common cause of the death in patients undergoing to the procedure. As for the open cholecystectomy in 13% of the patient is associated with higher transfusion rate of blood components than liver laparoscopic cholecystectomy, which is around 1.3%. And when we look at the series, usually open cholecystectomy patients are older and more likely to receive anticoagulant therapy and more often underwent emergent operation when we compare with the laparoscopic cholecystectomy patients. And bleeding complication requiring the reoperation occurred in 0.5% of these cases. As we know, gold standard for the treatment of gallstone is laparoscopic cholecystectomy. And uncontrollable bleeding, as it is shown on those different centers results, between the 0.1% to 1.9%. And the rate of mortality is below 0.1%. Can we divide the bleeding as an intraoperative and postoperative? As for the intraoperative bleeding, insertion of the Veress needle or trocar and consequence of improper dissection and operation techniques. As for the postoperative hematoma bleeding, can show itself as a hematoma or significant bleeding, which is missed operation injuries or slippage of the clips. Vascular injury, slippage of clips or ligature of the cystic artery, liver bed bleeding, miscellaneous result are the intraoperative bleeding pattern. And during the creation of pneumoperitoneum and dissection with the colored triangle are the main reason for the vascular injury. As for the common bleeding sites are the gallbladder fossa, thoracic insertion site, capsular tear, the falciform ligament, and the cystic artery. Vascular injury can be divided to the major vessels injury or minor vessels injury as aorta, vena cava, iliac vessels, right hepatic artery, portal vein, epigastric artery vessels, mesenteric and omental vessels. Most commonly injured vessels are the epigastric vessels. The peritoneum needle and the first thoracar is the most dangerous step in laparoscopic cholecystectomy, as it is essentially blind step of the operation. The majority of bleeding complications occur in this phase of the operation. As for the risk factor for entry-related complication, we can say many different factors: surgical experience, long thoracar, improper position of the patient, blind instrument, patient inadequately relaxed or failure to elevate the abdominal wall, incorrect direction or angle of the insertion of the thoracar, inadequate pneumoperitoneum, failure to rotate the thoracar during the insertion, forceful force, and inability to recognize the anatomical landmarks, extreme thinness of the patient, skeletal deformity, previous abdominal surgery, adhesion, and multiple attempts are the risk factors. Postoperative bleeding can show itself as a minor hematomas or significant bleeds. When we look at the literature, interestingly, these complications poorly documented and limited better their incidence, site, and management. And usually this complication require reoperation in a quite 5 instances. Postoperative bleeding can be internal bleeding and external bleeding. As for the external bleeding, usually manifest after the surgery from both sides, can be approached to this bleeding conservatively, but if it is failed, reoperation should be done. As for the internal bleeding, it is difficult to establish the site of the bleeding, may need re-exploration for its control, and persisting pain, tachycardia, fall in the hemoglobin and blood pressure should alert the possibility of bleeding. Bleeding from the liver bed can be seen 88% of the bleeding originated from the gallbladder bed, adherence of the middle hepatic vein, and it's radical to the gallbladder bed in up to 10 to 15% of patients is existing. This is a paper which is showing the close relationship with the gallbladder bed and the branch of the middle hepatic vein. And the CT confirmed the major branch of the middle hepatic vein and gallbladder bed in this paper. The median separating distance between these two structures is 6 millimeters. And 10% of the middle hepatic vein branches immediately adjacent to the gallbladder bed. And 10% of the major branch within 1 millimeter of the gallbladder bed distance. The mean diameter of this vein usually 2.1 millimeter. So, because of that, some groups have advocated the routine use of preoperative ultrasound to evaluate middle hepatic vein anatomy. Bleeding from the liver bed can be because of the operating in the incorrect plane and usually occurs during the final aspect of the removal of the gallbladder from the hepatic fossa. If initial attempts at laparoscopic hemostatic control phase requires immediate conversion to open surgery, oozing is important and very big problem in these patients, and hematoma also another problem. The culprit is usually a dislodged clip in this arterial source bleeding. The cystic artery identified and controlled with clips only if anatomical landmarks can be safely ensured, or else there is a high association with right hepatic arterial injury. Thoracar entry site complication is also very important. The type of the thoracar in this rabbit model showed that the relative risk of vessel injury induced by pyramidal tip thoracar is significantly increased compared with that induced by conical tip thoracars, especially if larger diameter thoracars are used. Smooth contour of the conical tip stretches and separates the tissue layers with little damage, whereas the sharp edge pyramidal tip lacerates any tissue it encounters. Obesity with a thicker abdominal wall and relatively shorter thoracar also can be one of the reasons for bleeding. And incorrect angle of thoracar entry, large diameter of thoracar, the open can be the reason for the thoracar site bleeding. So some authors recommend the open techniques and placement of ports on the rectus lateralis and viewing the veins before from the lights of laparoscopy from the inside can reduce the risk of vascular injury. When bleeding it's occurred during the operation, compressing with thoracar the bleeding area can be helpful, and maybe follow a catheter insertion from the thoracar side too, and the balloon is inflated at the bleeding site, or hemostatic agents can be used as a tampons, or laparoscopically suture can be placed. Hemostasis through the open method by enlarging the skin incision, if the other attempts fail, can be done. This is another techniques to stopping the bleeding. Author show in his paper, as you see the thoracar side active bleeding, and they are putting the cautery tip inside of the thoracar side, and they are coagulating the bleeding site. Bleeding may not be discerned until the end of the operation due to the compression properly of thoracar. Therefore, at the end of the operation, thoracars should be removed and checked under the laparoscopy, usually present subacutely during the first postoperative day. When patient present with bleeding, the diagnosis of hematoma can be made. Heterogeneous fluid collection on ultrasonographic examination. If ultrasonographic examination is not diagnostic, abdominal wall and intraperitoneal hematomas can be visualized on computed tomography. If the patient is hemodynamically unstable, a direct evaluation by real laparoscopy is advocated. Surgical factors, patient-related factors, and instrument failures are some of the factors implicated in the causation of the bleeding complication. As for the surgical factors, inadequate training and experience, rough techniques, improper usage of the instruments, inattentive handling of instruments, inadequate exposure, failure to recognize anatomical landmarks, and forceful retraction. As for the patient-related factor, acute cholecystitis, cirrhosis, portal hypertension, coagulopathy, adhesion, previous surgery, and anatomical abnormality. And defective instruments also the reason for the bleeding. Of course, the surgeon-related factors are the most important factors. Perpetuate lethal blood oozing after cholecystectomy is a rare but potentially life-threatening complication. This inflammatory alteration can be the reason of this problem, and chronic and recurrent cholecystitis, siderosis, fatty degeneration of the liver, thermal injury to the liver parenchyma are risk factor of postoperative hemorrhagia. Hidden blood loss can be seen laparoscopy-related postoperative mortality, and which increased by 15% when postoperative bleeding occurred, especially when the bleeding remains unrecognized. Higher hidden blood loss can develop in patients with hypertension if the gallbladder bed more than 50% of the gallbladder surface and operation time is more than 60 minutes. Hemophilia, very rare complication requiring angiographic examination and or operation for treatment. Mechanical stimulus of surgery added to the gallbladder wall with chronic inflammatory change. Extraordinary bifurcation of the hepatic and cystic artery, a micropseudoaneurysm, and easy bleeding due to resumption of anticoagulants. Peritoneal lavage can be the interesting reason for the bleeding. In general, vasodilatation occurs in superficial blood vessels at high temperature to facilitate the heat dispersal. Conversely, vasoconstriction is induced by cold to protect from heat loss, but it is usually followed by vasodilatation, which has the aim of avoiding cold-induced damage. Irrigation ensures a clean field that is essential to avoid injuries, precise identify source of bleeding. High temperature saline could be responsible for tissue damage. So 43 Celsius degree is the cutoff in human cells. Cold saline can trigger the vasoconstriction of partially dissected vessels, giving us the false impression of complete hemostasis. Then the following restorative phase could lead to bleeding at the end of the surgery. So observation of the hepatic bed should last at least 2 minutes after the peritoneal wash. This allows sufficient time to induce the vasodilatation, reflects in the vessels contracted by cold water. Perioperative hemorrhagic complication after elective laparoscopic cholecystectomy in patient receiving long-term anticoagulant therapy, it is with postoperative bleeding markedly more frequent in those patients, and risk of bleeding associated with the use of thromboembolic prophylaxis during the laparoscopic cholecystectomy, also with a high incidence of postoperative bleeding. This because of the small bleeding vessels being obscured as a result of the compression provided by pneumoperitoneum during the operation. Intrahepatic subcapsular hematoma of the liver without intra-abdominal hemorrhagia is an extremely rare and potentially life-threatening complication of laparoscopic cholecystectomy. Can be spontaneous normal manipulation of the gallbladder and liver can be cause of this complication, or due to the thoracal placement or excessive traction of the gallbladder causing the injury to the liver capsula, and excessive manipulation of the liver during the dissection of the gallbladder. Injuries being missed initially, there may be no obvious bleeding even when major vessels are involved. Retroperitoneal vessels do not tend to produce free intra-abdominal bleeding. The high intra-abdominal pressure may reduce the arterial bleeding. The majority of these complications are encountered in the setup phase of the operation, where the surgeon or the assistants are involved in the insertion of the thorax and the creation of the pneumoperitoneum. May be straightforward and obvious, but it may be missed if not suspected and carefully looked for. A generalized laparoscopy must be performed after the insertion of the first thorax. Presence of retroperitoneal or expanding hematoma near the site of insertion should be checked. Great care should be taken to avoid major complications, understanding the abdominal wall and liver anatomy, as well as the possible source and cause of bleeding during the and after cholecystectomy are important for reducing bleeding-related morbidity and mortality. I would like to thank for you listening to me, and you are very welcome to IASCO World Meeting Congress in 2022 in Hindistan'da. Thank you very much.
Thank you. Thank you very much, Professor Ender, for, I don't know whether he is available live as well, or this was just an recording.
We'll check, ma'am.
Yeah, yes, I am very sorry.
you
There
are
was
very
some
much available.
technical problem in the beginning.
We welcome you on behalf of organizers once again. Sir, it was a very extensive and elaborative talk on post-operative hemorrhagic complication of polycystitis. I think it is one of the complications which is looked into and deliberated less upon, with all focus on biliary crippling and bile duct injuries. And we would like to know from you that what is your experience about the what one of the very rarest complications you said is there is likely to be an intracapsular hemorrhage which can happen because of overtraction of the gallbladder, as the reporting in the literature is less. So do you have any cases what you have come across and managed in your practices?
Yes, actually, we don't have so much, but one interesting case which I can say, when my colleague put a drain to the after the cholecystectomy, and when we remove it after from the port side, this patient had this very severe bleeding, and we have to operate him again because of that bleeding. And of course, other reasons are also can be the source of the bleeding, but that's what I can say you in my experience as an interesting case.
Right. So it is much of an under-reported kind of a complication, wherein I came across a larger study from Finland, wherein they have seen some indirect evidences of more of hemorrhagic complications in post-cholecystectomy, wherein open cholecystectomy required more blood transfusions. It's a very, very large series of around 17,000 of lap and around 5,000-6,000 of open cholecystectomy, wherein they have reported that more than 10% of the patients did require transfusions and blood products, indirectly pointing towards the hemorrhagic complications of cholecystectomy. If anybody else would like to
Professor
put in some comments.
Can I ask you something? Your lecture was comprehensive, very nicely covered all the hemorrhagic complications, and I enjoyed your talk. So the patient has been operated and is in the room. When do you decide, how do you decide that this patient is to be taken back to the OT? Patient has some amount of tachycardia, some amount of restlessness. Are there any guidelines? Firstly, this thing. Second is, first varus needle we have put in and the blood starts coming out. So these scenarios you just describe for our listeners.
Thank you very much for your question, and I would like to thanks again to you for inviting me. As for the second question, of course, when you put needles, whereas needles, that's with the coming blood outside. This mean there's some problem here in there, so we should have to evaluate and check, maybe to look from the other side with the camera port to check if there is any active bleeding site in the varus needle site. And sorry, your first question, when we take out the patient after the operation to the department, you asked me?
I asked that how, are there any guidelines how you would decide that this patient is bleeding and you have to take him back? So the patient has been operated. In the post-op, he has some amount of tachycardia, restlessness. How do you decide to take this patient back to the OT? This is not an easy thing to be done.
Actually, in my knowledge, I don't know if there is any guideline regarding to this, but when we take the department to patient, the sign of the bleeding, we should have to follow. I mean, tachycardia, dropping in the hematocrit levels, or if patient has a drain coming through from the drain, any blood, And of course, we should have to take care of such kind of patient if the operation was difficult, and if the case it was difficult, so we should have to follow this kind of patient, I think, when we take them to the clinic.
Yeah, as Sir has put very rightly that we don't have any clear guidelines of when we should re-explore a patient, and maybe the general guidelines of amount of blood in the drain and the number of transfusion required and the drop in HP would be an indication of going in and operating. But for the first outset, we have to prevent the bleed. And as we're discussing the post-operative hemorrhagic complications, we need to pick it up at the right time. Prevention has to be as for students and those who are participating online, that the concerned surgeon, howsoever senior he would be, I think the way we start in very first cholecystectomy, we have a final look on our clips, we retract things and have a look that we haven't dislodged anything, would be a very important point. And if there's an ooziness in the bed or there is some dislodgement, and if you are a beginner, then you should always ask for a senior's help. I think those could be the tips. I could not get any questions from the question box over here.
Can I ask, Dr.
Yes, sir, please, sir, you get.
Yeah, Dr. Dulundu,
Yeah.
have you ever encountered any major aortic or iliac vessel injury, and how was it managed? I think this is a very rare thing, but
Yes.
if there has been an unfortunate kind of thing with any of the juniors.
Fortunately, I haven't had such kind of experience, but as I know, we should have to be very quick and very fast in this situation, and directly open the abdomen and putting maybe just putting your hand to control the bleeding, and after enlarging the incision, and maybe you can do it to yourself, or you can ask and help from the cardiothoracic surgeon. And of course, I think we should have to take the second opinion and ask to our colleagues to help to us.
Yes, one has to be careful, because these injuries may be through and through, and other organs may have also been injured. So if there has been major bleed, say operatively, how do you decide whether you would proceed for cholecystectomy or you would not proceed for cholecystectomy thereafter?
I am very sorry, I couldn't understand.
Okay, so another thing that I would want to ask you, or to elaborate upon, is if the patient has been on anticoagulants.
Anticoagulants, yes, okay.
Is there any special precaution that you would advise us?
Actually, there are several papers in the literature. They are saying that you can continue to the operation with even the patient as receiving the anticoagulants. But in my practice, as I show you in one paper also, using anticoagulants before the operation, even if you are stopping, and if the patient received it for a long time, this increasing the bleeding complications. So I usually stopped anticoagulation 1 week ago, and also for antithrombotic agents also I stopped, and after I'm taking the patient to the operation, because I believe, and I also show you some paper, those increasing the bleeding tendency on those patients.
That would also depend on how recent the cardiac event or the requirement of thrombosis was, and accordingly you may withhold 48 hours or a week before, or you may have to operate on same. With that, if sir or others don't want to make any comment, then we have done with our 30 minutes of this session. We thank Professor Ender for his very wise and nice presentation on hemorrhage in cholecystectomy.
Thank you, organizers, and thank you, Dulundu.
Thank you very much. I am very sorry in the beginning because of the technical problem. It was a great honor and pleasure for me to be with you. I hope we can have a chance to welcome you in Istanbul next year. Thank you very much. Thank you.
Thank you so much. Thank you.
Thank you. Bye-bye.
Thank you, Chairperson and Speaker, for the nice session.